Hello, this is Aditi Ambardakar with OpenAnesthesia.com and Anesthesia and Analgesia. I'm here today with Dr. John Mitchell to discuss his recent article titled Enhancing Feedback on Professionalism and Communication Skills in Anesthesia Residency Programs. It has been chosen this month as our Article of the Month for August's issue of Anesthesia and Analgesia. Dr. Mitchell is at the Beth Israel Deaconess Medical Center in Boston, Massachusetts, and is the Residency Program Director for the Anesthesiology Residency. Welcome, Dr. Mitchell. It's nice to have you here today.
Thank you for having me. I appreciate it.
For those who may not have had an opportunity to read your article yet, could you please summarize the study and its design for our listeners?
Of course. So I think as an educator, I feel like feedback provision is something that all programs struggle with, and especially that in the area of professionalism and communication. So as a team, we got together and we wanted to see whether just a brief, focused, video-based training program could be successful in augmenting quality, quantity, and utility of feedback overall, but more specifically related to negative constructive feedback or feedback on professionalism and communication, which were the focuses of our intervention sessions. So we collaborated as 4 mid to large size academic departments, including Beth Israel Deaconess, University of Kentucky, University of Rochester, and University of California, San Diego. And the program was very simple. It was 2 faculty development sessions on the provision of feedback with an emphasis on professionalism and communication and encouragement to supply constructive negative feedback. There was also 1 resident session on feedback provision, and we used the same moderator at each session. So I went to each of the programs and did the 2 sessions. My colleague Stephanie Jones did the 1 session at each for the residents. So we used quantity, quality, and utility of feedback, and then the presence or absence of feedback related to professionalism and communication and negative feedback as our endpoints. We collected de-identified daily written feedback from each center to assess these elements, and we used 3 months before, the time during as the intra-intervention between the 2 discussion periods, and then the 3 months after the intervention as the post period. It took about 10 months for us to complete the study across all sites, and we did not assess any of the feedback until the study completion. We used a team of 3 blinded raters to assess over 1,900 pieces of feedback as a group, and those feedback pieces were randomized by our excellent study coordinator. We rated the feedback on the presence or absence of those key things that I enumerated earlier related to quality feedback that we had selected from the literature based on a review of best articles in feedback quality. And then we first looked at data across all centers, and then we looked at each individual center for trends.
So as physician educators, we know that providing formative feedback is a global problem. Why did you specifically decide to focus on professionalism and communication?
You know, that's a great question, and it has a couple of explanations. The first was that at our center at Beth Israel Deaconess, and then also at many of the other centers that we included in this study, there had already been a push on to augment feedback in a general sense. And so we wanted to focus on the most challenging types of feedback to give, the thing that all of us are least comfortable doing, which is in the realms of professionalism and communication. Even as somebody that's an experienced feedback provider that's been doing this for years, those are still the interactions that are the most uncomfortable. So we felt like if we could train faculty to be comfortable doing those, they would also, by bulk flow, also be comfortable doing feedback on things like technical skills or knowledge base, which are a little more straightforward. The other reason for focusing on professionalism and communication is in the past we had done some work on other areas, as said some of the other study centers, and we wanted to make sure that the emphasis was a little different with this intervention.
Great. In their editorial, Drs. Huffmeyer and Kirk comment that professionalism is not learned if left to the observation and apprenticeship model, and further comment on the paucity of educational curricula for professionalism and anesthesiology residencies. What are your thoughts on teaching professionalism to our trainees? Can professionalism be taught?
I believe that it can. And while there are many components to professionalism, I think there's a pretty tight linkage between professionalism and communication, for example, and that many of the issues that we encounter within training programs center around miscommunication or lapses in closed-loop communication. And so we spend a lot of time focusing on that. both to define what our expectations for professionalism are, and in modeling excellent professionalism and teaching our staff to model excellent professionalism, as well as celebrating excellence in professionalism, I think is a critical component of what we do to train and teach professionalism. The reviewers are correct and the editors are correct. There aren't a lot of articles out there talking about curricula on professionalism in anesthesiology. And in fact, I was personally inspired to get more involved in this topic after reading a very excellent review article that Bob Geiser published in Anesthesia and Analgesia back in 2009 on this topic. In it, he did cite an article by Joyner and colleagues from the Journal of Urology in 2007, where they worked directly with their faculty and residents in their department to develop and make explicit the value of a professionalism curriculum, and were able to show gains in professionalism metrics through that explicit process. So one of the things that I learned through that is that if you're going to be explicit and set standards about professionalism, that can really help make sure you raise the bar on it. It was one of the things that really, I think, has helped us in our program. And so, for example, just today, in fact, it was the day that I spent inculcating my new trainees into the values of professionalism. I spend several sessions a year, but this was my first session with the CA1s, focusing on the importance of professionalism, sharing vignettes and stories about it, and explaining to them how it can be of importance in their career and how they can avoid common pitfalls in professionalism and communication. So I'm not just talking the talk, I'm literally walking the walk every day in this regard.
That's great. Let's turn back to your study. How did you decide with your co-investigators which institutions to enroll in this study?
So I identified collaborators. I wanted centers that were willing and able to complete daily feedback as part of this study, and that's not something that many centers in the country do. Through the Society for Education in Anesthesia that I'm involved in, I was aware of several other centers that did this and some other centers that were potentially interested in embarking on that pathway. And so that was how we identified the centers for the study, where we were looking for programs that were large enough that we would have a good mix of faculty and residents and a good power, but also programs that were willing and able to accomplish this daily feedback, which is no mean feat to accomplish.
For sure. Did the residents have any opportunity during the study period to give feedback to their faculty on the feedback that they received?
So that's an interesting point. Not as part of this study, but actually we have a two-way street in our feedback system that encourages the residents to provide feedback to their faculty, maybe not necessarily on the quality of their feedback directly, but also feedback to the faculty to kind of level the playing field and encourage that culture. We've also embarked at our center on a project where we audit the quality of feedback that comes in through our system and then provide feedback to the faculty on the quality using the rating system we developed for this study to guide especially new faculty in that process.
So how did you rate high quality feedback? In other words, what was the rating system you used? And in your opinion, what does constitute high quality feedback?
I think that's a really important question, and it speaks to the understanding of defining what the metrics were. We spend a lot of time looking through the literature as a team and trying to identify thematically what the elements of high quality feedback were. And the things that we settled on that came up time and again, and that we could also convert to a binary scoring system with several elements were as follows. We wanted to know if the feedback was detailed enough to give the resident a context and then something to recall, whether it was specific enough. And we'd separated out detailed from specific. So for example, detailed was maybe description of the type of procedures accomplished or what blade was used to facilitate an intubation or something, whereas specific would be, a comment on something to apply next time or the specific actions that a resident took. We looked at whether feedback was behavior focused instead of focused on attitudes, because that's very important. You can modify behaviors, but attitudes are subjective, and it's really gets into treacherous ground if people are commenting on attitudes in feedback. we looked to see if the feedback was constructive, or in this case, we inverted that so we could have a 0 for yes. So we asked if the feedback was destructive or harmful when we scored it. And that happened almost never in our almost 2,000 pieces of feedback, but it was worth having there because destructive feedback can really set back the whole tone of a feedback program and really set up a bad dynamic with a learner who then can't trust the system. We wanted to know if the feedback was actionable, and that point is extremely important, knowing whether somebody can do something with the feedback. If you just say something like good job, that doesn't necessarily tell a learner anything that they should do differently next time. And so even if people do in fact do a good job, we encourage through this process our faculty and the faculty at all the centers to come up with at least one thing the residents should do differently next time. And then we asked a question about, in our scoring system, separate from those points, whether the feedback was related to being negative constructive feedback and whether it was related to professionalism and communication, to see if our intervention moved the needle more specifically on those areas as well.
So what did you learn from this study? What can those of us that are privileged to educate our future physicians and anesthesiologists learn from your project?
I think one of the things that we all learned is that feedback is a very complex ecosystem. And even though these were 4 relatively similar centers, they all had different dynamics and different issues at play that needed to be addressed. And we felt like 2 sessions was opening an important conversation, and we wanted to make it something that was manageable. But realistically, to grow a feedback system, it has to be a culture shift that involves repeated conversations. I know for my part, it seemed like the best signal that we got out of this study was for new faculty. There was one center in the study that had been part of the initial pilot where they had only enrolled new faculty. And that center saw the most statistically significant differences in things like utility and quality of the feedback given. So I do this now with all of my new faculty coming in, and I make sure that they get at least 2 sessions and an opportunity. And then as part of the ongoing effort, I mentioned that we're going to be auditing feedback so that it's an ongoing effort, that certainly 2 sessions isn't enough to change the world, but maybe it's enough to start the ball rolling. And that maybe targeting newer faculty is a good way to change culture over time.
So, and what can you maybe give the residents or the fellows listening today, give them 1 or 2 take-home points from your study? Obviously, we focused a lot today on faculty. What could they learn from it?
Sure. For the future education researchers out there in the mix, don't give up on your goals. This project was born out of a shared interest of our group to try to improve feedback. And even though overall our metrics didn't show what we hoped they would show, we got a lot out of the project individually at our own centers and as a collective, and it spurred a lot of conversations that have been meaningful. So as future educators and researchers, don't be discouraged if you pick something complicated to work on. Just go for it and pick out pieces of the puzzle. The other thing that residents should be aware of is we got a lot out of the sessions where Dr. Jones met with the residents and talked to them about receiving feedback and the value of feedback to their education. And so that's something we do with our residents routinely as part of their resident as teacher program. We talk to them about receiving feedback and also to them about providing feedback, because if you're good at providing feedback and soliciting it, then that grows the culture as well, especially as some of those folks stay on staff.
Sure. Drs. Huffmeyer and Kirk did state that, and despite the statistical insignificance of the study, it indeed is an important first step to guide us educators in this important curriculum. And as you mentioned, Dr. Geiser's study back in 2009, you have moved the needle forward. Do you plan on any future studies that might help progress this content even further?
Absolutely. I mean, we've been lucky enough to have a big influx of new faculty to our group. And so we're trying to explore, since we saw the best signal with new faculty, as I mentioned, we're continuing to run a program similar to this with our new faculty, and we'll follow that longitudinally and see if that makes a difference. We're also using, as I mentioned, the metric that we developed in this for feedback auditing to see if we can help people improve their feedback longitudinally with a tool like that, which could be very powerful and very easy for people to use. By making it a binary tool, it's a lot less subjective. Once people understand the definition, we could get a reasonable correlation, although we chose to just do all of the feedback as a group rather than do it individually and try to do inter-rater reliability studies for ease. So those are two things that are ongoing, but we've also branched out to look at other avenues of professionalism and communication and are trying to use patient-centered data as well to influence residents' behaviors, because I don't think there's anything more powerful in terms of influencing professional behaviors and communication than hearing what your patients have to say about you.
Great. Thank you so much. I look forward to reading more about this in the future from you and your colleagues, and thank you for spending a bit of time with us today.
Oh, it's a pleasure. I really appreciate your time as well and the opportunity to discuss this work.
Thank you so much. Bye-bye.
Bye.